Hi again. After a long gap, I'm doing my new video. As you can hear probably from my voice, I had a respiratory infection or a cold, and that took away my voice and cough, and so I could not do anything. But anyway, Happy New Year. I'm going to start with some of the videos on diagnosis of asthma, and this is one of the commonest conditions. I'll go back to the theology after a few videos on medical diagnosis. So I'm starting with asthma. Many years ago, we used to define asthma as completely reversible airway obstruction. In fact, when I used to do lectures on asthma to the medical community, I used to say that asthma is like Hershey's commercial. Now you have it, now you don't. So it was felt that there was a constriction of the airways or the bronchial tubes. And so during that time, when people had attack, that constriction caused people to be short of breath, produce more mucus, they were wheezing, and they had treatment or without treatment. When this reversed, they were completely normal. So the now you have it, now you don't type of a picture. The airway constriction is just like breathing through a straw. If I would pinch somebody's nose, put a small tube in his mouth, and ask him to breathe through that small tube, somebody's going to be short of breath. Because as you know, the laws of the physics, as the narrowing of the tube occurs, the resistance quadruples. So if the narrowing is half, the resistance is 4 times. So certainly breathing through a straw or breathing through a narrow tube causes shortness of breath. But over a period of time, we have realized that the asthma is actually a much more than just constriction. So now we know that there is an associated inflammation. The inflammation leads to more mucus formation, irritability of the bronchial tubes. So there is more cough, there is mucus formation. As the drainage of the mucus is limited due to narrowed bronchial tubes, we have more mucus plugging, and that causes difficulty for air to get in or oxygen can drop. So essentially, the new definition, and I'm not going to the medical definition, is that there is an associated inflammation which leads to irritability, which leads to constriction. And the primary etiology or the cause is inflammation. And primary treatment should be focused on a long term on reducing the inflammation in the bronchial tubes. So in past, we used to give epinephrine or adrenaline and bronchodilator, the medication that open up the bronchial tubes, to reverse the attack of asthma. It is still done. However, we are now realizing and addressing the inflammation. Because if you treat the inflammation and do not allow the bronchial tube to react with an inflammation, edema, swelling, more mucus formation, the need for bronchodilators is reduced. As you can imagine, I just said something, that the bronchoconstriction is reversed by drugs which are like adrenaline or epinephrine. Adrenergic drugs cause increase in blood pressure, increase in heart rate, and sometimes are not the best for some of the older patients. So treating bronchoconstriction alone is not a treatment of asthma anymore. Reducing inflammation is the basic treatment. Now, I'm not going to talk about allergies and allergy-induced asthma in this particular video, which we will cover in the near future videos. But just to give you an idea about the reversibility and treatment of inflammation, we will talk about it pretty soon. So if you consider any disease, whether it is high blood pressure, diabetes, or even cancer, People say, well, is it stage 1? Is it stage 2? Is it advanced stage? People say, is it mild high blood pressure? Is it mild diabetes? Is it severe diabetes? Is it severe hypertension? Same way, the asthma is classified into a mild, moderate, and severe. In addition to these three usual classification of any disease, the asthma is also classified into a mild variety, which has two different: mild intermittent and mild persistent. So when people have continuation of inflammation and the bronchoconstriction on a breathing test or clinically is when you take the history, people say they're short of breath, they have cough, they wheeze, and they get better with inhalers. Or on a physical examination, when you listen to somebody's chest and you hear the bronchospasm, or in the laboratory, when you do the breathing test and you find out that they are obstructed, their flow, the peak flow, the flow of the air that they can exhale is reduced. This is considered as asthma, and whether it is mild or moderate or severe is classified based on all three: history, physical, and the lab or the pulmonary function studies. I'll talk about the pulmonary function studies a little bit in greater detail maybe next time. But at this time, I just wanted to say to you that mild intermittent asthma needs mild intermittent treatment. The mild persistent, moderate, and severe need a treatment almost all the time, whether in a less or more dosage form. So to say that people are going to need anti-inflammatory and a bronchodilator in a combination in a severe asthma is a correct statement. They also need anti-inflammatory and a bronchodilators in a moderate asthma all the time. But mild intermittent you could get by using an inhaler as needed. That means when you have an attack. For example, people may have an attack when they exercise. People may have an attack when they get exposed to chemicals like hairsprays, perfumes, laundry detergent, dust, molds. So when they get an attack at that time, they could use an inhaler that will reverse them quickly. If the need for the inhaler is more than 2 to 3 times a week, you are actually looking at mild persistent. And in the mild persistent asthma, you need a combination of drugs, which includes anti-inflammatory, which is inhaled corticosteroids or steroids, and the bronchodilator. So one may question, what will happen if I continue to use just the bronchodilators because I'm worried about steroids and steroid side effects? It has been proved that those kids who had asthma and who were treated only with bronchodilators, not with inhaled corticosteroids, had their adult pulmonary function studies showing that they were less than their colleagues or comparable kids who did not have asthma. So untreated persistent asthma does lead to permanent damage, which sometimes may become non-reversible in spite of treatment. So if somebody has an asthma and it goes untreated for years together with an anti-inflammatory, and people continue to use just an inhaler bronchodilator form all the time and need it daily, at the end of few years, they will have a permanent damage to their bronchial tubes and lungs. So please remember, you need to combine anti-inflammatory in a steroid form and a long-acting bronchodilators in patients who have severe asthma, moderate asthma, or mild persistent asthma. I'll be talking about the breathing test and how to define these mild, moderate, severe variety in my next video. Hope you like it, appreciate, like it, subscribe it. Thank you for watching, and once again, Happy New Year for 2020.